This conference will now be recorded.
Hello, good morning. Today's class is on amniotic fluid and its disorders. Before going to the class proper, you should know about the amniotic fluid. This origin of amniotic fluid is very much important, but the origin is mixed in origin. It is both maternal and fetal origin. The amniotic fluid, it is like a water, is completely changed and replaced every 3 hours. This contains long overhead. Epithelial scales in the meconium shows the fluid is swallowed by the fetus and some of it passes through the gut into the fetal plasma. So you should know how much will be the volume at each gestational age. In 12 weeks age, it will be about 50 ml. 20 weeks, it will be around 400. And 36 to 38 weeks, it reaches its peak. It is about 1 liter. This you have to remember. And later, up to 40 weeks, it will come to 600 to 800 ml. As the pregnancy advances, the amount will still decrease. So here we are important one is 36 to 38 weeks. It reaches its peak amount. It will be 1 liter. Later, it decreases on its own to 600 to 800 ml by 40 weeks. Coming to the physical features, the pH will be alkaline. Specific gravity is 1.010. Color is usually colorless. But at term, it is about pale straw color will be present. And this color is very much important in some of the diagnosis of the diseases and distress. If the color is green color when the membranes are ruptured, it is mainly due to meconium. So it indicates fetal distress. If it is golden color, it indicates the RH incompatibility. Greenish yellow, post maturity we should think of. If it is dark brown, tobacco like juice, always think of intrauterine death of the fetus. If it is dark colored, it can be an accidental hemorrhage due to separation of the placenta. There will be bleeding into the amniotic fluid. So, important thing is green color, meconium staining, golden color, RH incompatibility, green color, post maturity, dark color, blood stain is accidental hemorrhage, and dark brown is due to intrauterine death. And composition will be water, most of it will be the 98 to 99% water, and few solid components will be present. What are the solid components? It can be an organic or inorganic compounds. Organic compounds include proteins, glucose, uric acid, creatinine. You need not remember the amount, but the ingredients you should remember. Blood urea, creatinine, uric acid, protein and glucose, and lipids also will be present. And not only that, hormones, for example, prolactin, insulin and renin are also present in amniotic fluid. And the inorganic components are sodium chloride and potassium. And not only these, there are some suspended particles. They are longo, exfoliated squamous epithelial cells from the fetal skin, vernix caseosa, and cells from the respiratory tract, urinary bladder, and vagina of the fetus. So, this is the composition of the amniotic fluid. And what does it do? This amniotic fluid, the main function is to protect the fetus. During pregnancy, it acts as a shock absorber and it maintains the even temperature around the fetus. And not only that, it prevents adhesion and allows the free movement to the fetus. But the nutrition value is very negligible. And during labor, it forms the wedge for the dilatation of the cervix along with amnion and chorion. And during contraction, it prevents marked interference with the placental circulation. It prevents compression of the umbilical cord, and it acts as a bacteria. This contains a bactericidal property and protects the fetus from the ascending infections. So during pregnancy, shock absorber maintains temperature, and for the free movement, it prevents the adhesion. During labor, it forms the wedge along with amnion and chorion for the dilatation, prevents cord compression, prevents the placental interference in the placental circulation, and bactericidal. So how this amniotic fluid is formed? I already told you it's a mixed origin from maternal as well as the fetus. So the production can be from the transudation of the maternal serum in the beginning of the intrauterine life. Later from the fetal skin. This skin is up to only 20 weeks. Later what will happen? The skin will become thickened, that is keratinized. Later the function, that production activity is taken by the fetal lungs and fetal bladder. So transudation from the maternal serum, transudation from the fetal circulation across the umbilical cord, transudation from the amniotic epithelium which is surrounding the amniotic cavity, that is secretion from the amniotic epithelium, transudation of fetal plasma from the skin, fetal urine, daily output at term is about 400 to 1000 ml, and fetal lung. So these are the 6 things we have to remember: maternal transudation, fetal transudation, secretion from the amniotic epithelium, from the fetal skin, lungs, and urine. And for the removal, fetus swallows about 500 to 1000 ml of liquor every day. Not only that, there can be intramembranous absorption of the water also will be present. See, this is the maternal circulation. How the amniotic fluid is formed? Because of maternal, placental, amniotic epithelium, fetal skin, and fetal urine. This is the formation. For the exchange from the swallows and from the intramembranous exchange will be present for the removal. So we are going to the topic polyhydramnios. Our topic today is polyhydramnios. So what is polyhydramnios? Anatomically, polyhydramnios is defined as a state where the liquor amnia exceeds 2000 ml. At 36 to 38 weeks, how much I told you? It is 1 liter. Later it decreases to 40 weeks, it is 600 to 800. That is the maximum point. But here it will be more than 2000 ml. And there is also a clinical definition where the excess amount of liquor amni causes discomfort to the patient and amniotic fluid index is more than 24 centimeters or single deep pocket. If you take one single pocket, if the measures more than 8 centimeters or 4 quadrants, we will take umbilicus as a midpoint. We will draw a line from at the level of umbilicus horizontally and vertically from Ziegfeld sternum to symphysis pubis. So it will divide into 4 quadrants. When you sum up the amniotic fluid volume in 4 quadrants, that is gives the amniotic fluid index. If it is more than 24 and deep vertical pocket is more than 8 centimeters, we will call it as polyhydramnios. The incidence is only 1 to 2%. See, this polyhydramnios can be defective absorption or excessive production. So what are the causes for the polyhydramnios? It can be fetal, maternal, or placental. What are the fetal causes? Most of the fetal causes are anomalies. What are the anomalies? See here, this is the anencephaly. Here the fetal skull is absent. Okay, esophageal atresia. There will be narrowing at the level of esophagus. Spina bifida, cleft lip and cleft palate, hydrocephalus, and chromosomal abnormalities. These are the few fetal anomalies which are displayed here. What will happen in anencephaly? This most of the time the examiners will ask, because we are also having specimen in our department. In the exams usually we will ask. See what will happen? Congenital fetal malformations are associated with polyhydramnios in 20% of cases. Example are anencephaly. Why there will be excess production of liquor amniae in anencephaly? Because of exposed meninges. There is no vault. There is no cranium. So the meninges will be exposed here. There will be transudation from exposed meninges. There will be absence of fetal swallowing reflex in this anencephaly baby. They can't swallow. Number third, there will be suppression of fetal antidiuretic hormone. So what will happen? There is excessive urination. There is the anti-ADH will be suppressed. So there will be excessive. These are the three causes. Usually the examiners will ask you. There will be transudation from the exposed meninges, absence of fetal swallowing reflex, and possible suppression of fetal antidiuretic hormone. Okay. Then open spina bifida. Here also, increased transudation from the meninges, esophageal and duodenal atresia, it prevents swallowing, isn't it? Then facial cliffs and neck masses. These neck masses also will interfere with normal swallowing, RH incompatibility, or any genetic syndromes. See, these are the diagrams. And coming to the placental causes, tumor of the placenta. What is the tumor name? Chorioangioma of placenta. It arises from the single villus, and there will be hypoplasia of blood vessels and connective tissue that leads to increased transudation. So chorioangioma of placenta is important. Number third one is multiple gestation. Hydramnios is more common with monozygotic twins, especially when they are having TTTS. Have you heard of twin-to-twin transmission syndrome? In that condition, there will be one will develop polyhydramnios and other will have oligohydramnios. And maternal causes include mainly diabetes. See, this polyhydramnios case is also a clinical case. They will ask you about diabetes also. So what will happen in diabetes? There will be the diabetes is not controlled. Uncontrolled diabetes leads to maternal blood sugar will be raised, isn't it? Raised maternal blood sugar leads to raised fetal blood sugar. Whenever their blood sugar is there increase, there will be diuresis, isn't it? They will go for frequent micturition. That is, fetal diuresis will be present, and that leads to hydramnios. And not only that, cardiac or renal diseases may also lead to edema of the placenta, leading to increase in transudation. There are two varieties of polyhydramnios. So till now, maternal, fetal, and placental causes. All three are shared for the etiology. Maternal are diabetes, cardiac and renal pathology. Fetal are congenital anomalies. Important ones are anencephaly, open spina bifida, atresia, esophageal atresia, cleft lip and cleft palate, and genetic syndromes. And multiple gestation with TTTS syndrome. These are the fetal causes. Placenta or chorioangioma placenta. These things you have to remember. And what are the types of polyhydramnios? Clinically, they are divided into acute and chronic. Among these, chronic is most common. It usually, chronic variety, as you know, it usual onset is insidious, very slow. It takes few weeks to develop. In acute variety, onset is sudden. Within few days, it will develop. And sometimes acute can also develop on chronic variety. And sonologically, we can divide polyhydramnios into mild, moderate, and severe. Mild means if they have deep vertical pocket is more than 8 to 11 centimeters, it is called mild. Very simple. 8 to 11, 12 to 15 is moderate, more than 16 is severe. See here, they will measure like this. Here, this is ultrasound picture. Deep vertical pocket, which is the biggest side we will take, we will measure this. If it is more than 8 to 11 centimeters, it is considered as mild. More than 12 to 15, moderate. And more than 16 is severe. So what are the symptoms usually the patient complains? Most of the time, this polyhydramnios, as it is chronic, it is a clinical finding which is diagnosed by the obstetrician by ultrasound, during ultrasound examination or by report. And if it develops severe form, they can develop respiratory, shortness of breath, palpitations, edema on the legs, and varicosities of legs or vulva, and hemorrhoids will be other symptoms. And what are the signs are? She will be dyspneic because of respiratory embarrassment and especially in the lying down position. Sometimes preeclampsia is associated with this polyhydramnios. Preeclampsia, edema, hypertension, proteinuria will be present. When coming to the abdominal examination, by inspection findings will be abdomen is markedly enlarged. Whenever the abdomen is markedly enlarged, the skin will be tense and shiny, and large abdominal striae gravida will be present, and the abdomen looks globular and fullness in the flanks will be present. And palpation, height of the uterus will be more than the period of amenorrhea. If you measure the girth of abdomen, it will be more than normal. Fluid still can be elicited, and because of the excess amount of fluid, the fetus lie, presentation, position cannot be well defined. We have to take the help of an ultrasound. External ballotment can be elicited more easily. On auscultation, fetal heart sounds may not be heard distinctly. We may need the help of Doppler or scan. And if you do PV examination, cervix may be pulled up and partially taken up also, and one finger dilatation can be usually elicited, and there will be bulging of membranes can be felt by the fingers. So what are the investigations we have to do when a patient comes with polyhydramnios? Apart from routine, you don't start with higher investigations, always start with hemoglobin. Hemoglobin, urine albumin, sugar micro, blood grouping and typing, blood sugar. Because as the polyhydramnios is associated with PET, we have to see for the renal function test. And amniotic fluid, especially alpha fetoprotein estimation is important. This alpha fetoprotein estimation is important because it will be raised whenever there is open neural tubal defect of the fetus. And not only that, the important investigation is ultrasonography. This ultrasonography is, what are the things we can see? We can see whether the fetus is single or multiple. If it is multiple, monozygous or dizygous. And we can see for the live presentation position, amniotic fluid index. And not only that, we can see any anomaly is there in the fetus to develop this polyhydramnios. And how you are going to manage. And we first think early detection and control of diabetes. If the mother is diabetic, associated features will be factors to be controlled. If it is having PET, we have to control her blood pressure. RH immunization, it is now preventable by giving anti-D injections. And any anomalies we can see in the beginning, we can give genetic counseling or previous history of anomalous baby. We can give genetic counseling, and we can also start folic acid tablets before the conceive them until 3 months before the patient conceives. And treatment is polyhydramnios is usually according to the underlying cause. If it is mild, nothing to worry. Wait and watch policy will be enough, because as I already told you, as the pregnancy advances, there will be decrease in liquor on its own. So 36 to 38 weeks it will be later it will decrease. So slowly it will decrease, nothing to worry. Only in severe cases, we have the principles in management are, one thing is we have to relieve our symptoms, problem, and we have to find out the cause, and we have to deal with the complications are there. We have to ask her to take bed rest. Supportive therapy is treatment associated with conditions like preeclampsia and diabetes to be ruled out. And we have to start, so the use of diuretic, there is no value. We can start COX-2 inhibitors, Sulindate 200 milligrams every 12 hours. And we have to hospitalize the patient whenever there is severe polyhydramnios. And what are the investigation? This is the here chart is there. We have to give all the investigation, postmortem blood sugar, GTT, glycosylated hemoglobin, any infections, and ABY incompatible blood grouping to be seen, ultrasound diagnosis, and if the baby is having any anomaly, immediately pregnancy to be terminated. If no fetal abnormality, and the response to the patient, the response is there for the treatment. If it is transient, mild cases, no maternal distress, we can continue the pregnancy. Management of the complicating factors, if any, are to be treated, and delivery should be done at term. If the mother is having any distress, if it is less than 37 weeks, still we have to continue the pregnancy, means we can go for amino reduction. If it is more than 38 weeks, we can stabilize the lie and presentation by oxytocin drip, ARM can be done, and delivery can be conducted. What is this amino infusion? Amniocentesis is slow decompression is done at a rate of 500 ml per hour, and the amount of fluid to be removed should be sufficient enough to relieve the mechanical distress. See, this is a diagram. Under ultrasonic guidance, we will remove the amniotic fluid. It should be 500 ml per hour, so that by ultrasonic guidance, so that we won't injure the placenta or fetus. Okay. Normally, amino drainage is stopped when the amniotic fluid is less than 25 centimeters. Because of slow decompression, the accidental hemorrhage is less. But the problem here is, again, the liquor can accumulate. And what the advantage of taking this amniocentesis is, this can be tested for fetal lung maturity also. And what are the complications? They will ask this in exam, definitely. What are the complications with polyhydramnios, maternal and fetal complications? Maternal complications are, I already told you, preeclampsia is always associated, 25% chances. Malpresentations are more common. Premature rupture of membranes because of overdistension, and preterm labor are more common. Not only that, due to sudden gush of rupture of membranes, there are more chances for accidental hemorrhage. And not only that, during labor, there can be early rupture of membranes, cord prolapse can be present, uterine inertia. Because of malpresentation, there can be operative delivery, and retained placenta and postpartum hemorrhage are the complications, and shock of the complication we'll expect during labor. During puerperium, subinvolution, because overdistended uterus may go into subinvolution, and not only that, because of operative interference, there are more chances for infection. And coming to the fetus, they can be prematurity, congenital abnormalities can be seen, and not only that, increased operative delivery and other complications can be seen in the fetus. So, pregnancy, PAH, malpresentation, premature rupture of membranes, preterm labor, accidental hemorrhage. Here are during labor, early rupture of membranes, cord prolapse, uterine inertia, postpartum hemorrhage, operative interference, and shock. Puerperium, subinvolution, and sepsis. Coming to the acute polyhydramnios, acute hydramnios is extremely rare. The onset is acute and flame occurs within few days. This usually occurs before 20 weeks of pregnancy, and I already told you it is associated with monozygotic twins with TTTS or choreangioma placenta. What are the symptoms they can have? Same, abdominal pain, nausea and vomiting. The patient looks ill, absence of features of shock, edema of the legs are present. At the 20th week, she may develop PAH. Abdomen is hugely enlarged more than the period of amenorrhea. Fluid fill is present as polyhydramnios. Fetal parts cannot be made out. And internal examination reveals taking up of the cervix and even dilatation of the os and bulging of the membranes are found. Sonography can show multiple fetuses or sometimes fetal anomalies also. Treatment is most often spontaneous abortion occurs sometimes, most of the times. In case of severe TTS, amino reduction until the amniotic fluid is normal, and sometimes they can go for the laser ablation. Thank you.